All right, it's an honor to have Dr. Rahul Gupta on the podcast. He's the head of the White House Office of National Drug Control Policy, otherwise known as the Drug Czar. Notably, you are the first medical doctor to serve in this position ever. It's a position that goes back several decades, the Nixon administration. I have been following a number of the developments, and I want to get to your big announcement regarding marijuana. But first, I want to start a bit with your background here, your approach to the position, doctor, as a medical doctor, and I think for many folks, a better understanding of what your office does versus, per se, the DEA.
First of all, as a physician and someone who's actually still practices medicine and has done that for well over 2 decades, it allows me to have direct contact with people and be in communities, and then have to work with folks both who are dealing with not only the disease of substance use disorder, but so many other conditions, oftentimes in the same person. So it allows me to have that patient or person-centered approach in the real meaning of the sense that it is. The office basically is the one place where the president's drug control strategy is published every 2 years. We published the President Biden's inaugural strategy in 2022 and just have published the update in 2024. What the strategy does is to look at how, as one government, can we address this important issue of illicit drugs. So when we looked at it, we saw really two big drivers. One is untreated addiction. That's the public health side of this. And the other is drug trafficking, especially with the profits. That's the supply side of this. And the other piece of this, what this office does is then, after publishing and sending it to Congress and sharing with the public, we also have the budget angle. So we're able to work across 19 federal agencies that range from health agencies like FDA, CDC, and SAMHSA, and NIDA and NIH, to other agencies like Department of Justice, DEA, Department of Defense, Homeland Security, and so many others, to really bring together the experts in all directions and from all directions, as well as international partners, to address this. The budget oversight is about $44 billion, and it allows us to be able to more effectively execute the president's strategy when it comes to drug control, drug policy issues.
So you're taking more of a 10,000-foot view versus, say, the DEA, which is specifically doing law enforcement.
Exactly. So our goal is to look at this as one issue that affects people at the center of it, and start to move out all the way from global supply chain issues when we talk about fentanyl. The fact is today, for the last about 8 to 10 years, the drug space has evolved like it has never done that ever in the human history. Reasons for this are several. One, we've gone and we're moving away from organic drugs into synthetic drugs, which are much more lethal in small amounts. They're marketed differently, they're consumed differently. And secondly, this change is leading to exponential rise in overdoses, exponential rises in disease of addiction, which is now we know as a brain disease. And it has so much more complicated sort of factors that include housing, it includes workforce opportunities, it includes transportation, childcare, you name it. All those aspects become important when you're talking about individuals.
Yeah, you take us to the next question, which is, looking at the numbers here, some of the recent numbers that I saw, numbers when it comes to overdoses have doubled over the last decade, especially with fentanyl. There's a story out as we speak from the Washington Post talking about the doubling of overdoses among young people, 12 to 17-year-olds. We hear, I hear from members of our community, the Mo News community, nearly every week, sadly, about a loved one that they've lost to addiction. Heartbreaking. And it makes a lot of people feel like, what's being done? Give us a sense of where we're at and how you've been approaching just this escalation we've seen in ODs.
Absolutely. And this is where these strategies are really based in evidence and driven by data. So to give you an example, when President Biden came into office, we were seeing double-digit rises in overdose deaths, up to 30% a year. And just last week, we saw the newest CDC data from 2023 preliminary that shows a 3.1% decline. The reason that's important is in any epidemiological sort of large epidemic, you are going to see in going up, then you're going to start to see flattening if things are working, and then you're going to see decline. So some of the policy we've taken, like making sure that naloxone or the antidote that's for overdose when you're overdosing from opioids is available widely, just like a defibrillator or a fire extinguisher. We made sure that people have access to treatment. That's been a big problem in the past to not have access, whether it's remote telehealth opportunities, is behind the wall opportunities, or otherwise really expanding that. And every one of these aspects is following the data. Another one is making sure we have recovery space. We have more recovery-friendly businesses now because it makes sense to have hire people, and recovery is good for the bottom line, and then prevention. At the same time, we're really going after the commerce of drug trafficking. We've seen through our experience that, look, catching the slowest moving gazelle, so to speak, and putting people and locking them up is not the solution. What we have to do is understand the commerce, and then we have to go after the very choke points within that commerce, and whether it's sanctioning, whether it's disrupting the trade and commerce of this illicit trade is important. But remember, when we talk about 100,000 plus people dying, also that it's only the tip of the iceberg. Underneath that is the entire about 48 million Americans who are suffering from substance use disorder.
Talking about almost 15%, 12 to 15% there of Americans.
Exactly. And when we look at non-fatal overdoses as opposed to fatal overdoses, that can range anywhere from 8-to-1 to 15-to-1, meaning that people get a lot of non-fatal overdose before they ultimately die. So goal for our office is not only, which is very important to focus on the fatal overdoses, but also the non-fatal overdose and the disease of addiction per se. There is a complete pyramid. Explaining that, understanding it, and taking a data and evidence-based approach to addresses is how we're going to get across and actually be able to save more lives.
So it sounds like, I mean, despite the fact that it's just a slight 3% drop in the numbers, a couple thousand people, I mean, do you feel like we've turned a corner here?
I'm hoping so, because the policies that we have enacted seem to be having that effect, because it's very important that, is this a blip on the radar, or is it actually one that we can sustain by doubling and tripling down on the policies piece? We do feel strongly that it's the latter, not the former, because we've seen the flattening in 2022 data, and we had predicted that back in 21, that if we do this right, this is. So if you just look at that, the delta, the gap in what we predicted, if we did nothing or continue the same policies and where we are, is about 40,000 lives. That's the change that has happened overall just by enacting these policies. Now, we can do a lot more. I'm interested in getting treatment universally behind the walls. We think we can save up to 17,000 lives a year by that. Expanding naloxone further, we can save probably about 26,000 lives that way. So there's a lot of data that we're developing and impacting with the single goal of the North Star of saving lives first, and then getting people the help that they need.
And then what about the route fentanyl is taking into the country and that? Because I know there's been talks with the Chinese about some of the ingredients, and there's this whole supply chain of fentanyl coming into the country.
Yeah, we're really interested in not playing whack-a-mole, but actually starting to go to the root causes. Because what happened in the past, which was a success, we stopped having fentanyl coming directly shipped from China to the United States in about 2019. But what we have seen since is these precursor chemicals, those that you can turn into fentanyl, began to come either through the United States or from the United States and go to Mexico and then be produced in fentanyl and then being shipped from the southwest border, illegally trafficked. So what we're trying to do now is to work with the counterparts in China to say, look, this policy doesn't work. We need you to have better control of your industry, so there is no illicit commerce or sending these shipments. We're working with Mexico also. And then we're also, the president's been focused on putting more drug detection scanners. That's technology of the 21st century at our ports of entry, because it turns out that 90% of the fentanyl that's coming through is coming through legal commercial ports of entry. And we only scan about 5%, and that's been true historically across administrations. And the president wants to make sure that 100% of all vehicles that need scanning get scanned. And that's why we're also pushing for more and better scanners at legal commercial ports of entry.
I want to get to the marijuana move in a second, but one more question on fentanyl. A question I often get from people is, why do the drug cartels put fentanyl in the drugs knowing that it's killing so many people? Explain the rationale here on the part of both the Chinese with the precursor chemicals and the drug cartels, and why fentanyl is ubiquitous these days.
Yeah, we put a lot of effort in understanding why this is happening. And one thing we see is at the end of the day, look, this is a business for them. What they're trying to do is put just enough fentanyl, because it is an opioid. It is a powerful opioid, about 50 to 100 times more potent than morphine, that one can get addicted to. So the goal here for them is to expand the base of users. And the side effect of that, the collateral damage, is some of those users die. Because we know that, for example, someone who is naive to opioids will have more effect of a smaller dose than someone who's been using it for a while, and because tolerance develops. So while they can't control for everyone, their business model is to expand. And that's why they put a certain percentage of it in those pills or supplies. But the goal certainly is to make money off the suffering of vulnerable Americans. And this is one that's a global threat now. This is not limited to the United States, unfortunately. This is something that we may have been the canary in the coal mine, so to speak, but now we're seeing synthetics being impacted in the world, in countries. We put up a global coalition. We began last year. Now we have over 150 countries that have joined up because they know that either they have a problem and they're not aware of it, or they are a problem that they're aware of it, or they're going to have a problem in the future. So this has become a global threat, and that's why we're working with countries like PRC, China, to make sure that they're held accountable.
All right, so let's talk marijuana here. The war on drugs, decades old. I grew up in the 80s and 90s. I remember the Just Say No campaign, the T-shirts. As I was growing up, I remember learning that marijuana is a gateway drug that'll lead me to abuse others. What have we learned about that strategy? Because I think if somebody from the 90s found out the move that you're making now, they would be surprised.
Well, let's start first that we've had, when it comes to marijuana, failed policies for more than half a century, because of which way too many lives have been upended. We have had a failed approach in where we have so many people incarcerated because of it, and so many people their lives have been basically destroyed. Give you an example. We know that the use of marijuana across all populations, the rates are pretty similar, but Black and brown people are arrested, prosecuted, and incarcerated for much higher proportions. We also know that when that happens, you have a conviction, then you have barriers to housing, you have barriers to employment, barriers to small business loans, and so much more. So for tens of thousands of Americans, their life has been sort of fell apart because of this one conviction, whatever the age that might be. And that's why the president's been very clear that people should not be jailed for just using or possessing marijuana. It's important to recognize also the science, what it's taking us now. Now, that having said that, of course, for young people, the brain is still developing up to the age of 22 to 25, and we got to make sure that they're not exposed to any substance, much less marijuana or something else, because it does interfere with the development of the brain. But since last several years, we have gotten a lot more research, not as much as we would like to see, but a lot more research now into the uses of marijuana.
So it's not just a financial thing. I mean, these states now, I think we're almost exactly half the country, half the states have legalized it recreationally. 2/3 have legalized it medicinally. And a lot of people are saying, well, you're making a lot of tax revenue off of it, despite the health impact.
Yeah, I, as a commissioner in West Virginia, I was actually the medical cannabis program landed in my shop, and obviously we did a pretty good job of moving forward with that. But it is about following the science as well. The question here becomes look, this is one that has not only destroyed lives, but there are some benefits that we have not appreciated. And so this drug remains in the category, Schedule 1, right next to LSD and, ecstasy and heroin. So we got to make sure that we are following science and analyzing substances for potential benefits, especially with the data that exists.
Yeah, so you mentioned Schedule 1. That's where marijuana has been in the company of heroin, LSD, ecstasy. The decision recently skip over Schedule 2, which is like Adderall, Vicodin, and marijuana in the near future will be Schedule 3 alongside Tylenol and codeine. Explain to me the move there and what that means, both for the average American, for the business of marijuana, et cetera.
So the Federal Controlled Substances Act has these schedules from 1 to 5. And Schedule 1 is basically no medical use at all and high potential for addiction. And then with Schedule 2 to 5, providers can write prescriptions for medications. Obviously, Schedule 3 would mean that there are medical uses, and obviously for that reason. And what happens when that occurs, and there has been a process, President Biden asked Department of Justice and Health and Human Services back in late 2022 to independently evaluate the science behind this and come to a decision on this, while also he's since pardoned several times individuals in federal custody for simple possession or use of marijuana, and has asked state governors to do the same. What this does is basically allows marijuana to become Schedule 3 drug, and obviously there will be drugs that will be developed that will have to go through FDA approval process and all of that. But it does allow the recognition of the medical uses. More importantly, it also allows the opening of research. It's critical because the research for over half a century has been lacking significantly in this field to see the current and more benefits in the future, more product developments. We may have new products that may be able to help with or cure diseases.
So the move to Schedule 3 allows that research to take place.
Exactly. And for the products to be developed for marijuana for Schedule 3, it also will help people with chronic conditions like cancer or chronic pain or others as well.
I have heard from some doctors who work with addiction. I know you've worked with people in that way as well, who have expressed concerns about some of the more potent strains of marijuana that they've seen out there, and the concern about addiction to marijuana, that the marijuana that people are smoking and utilizing these days is not the marijuana of yesteryear.
That's exactly right. Look, the THC concentrations are extremely high these days. And so high that, when we talk to my colleagues, pediatricians and others, while they may not be always trained into the addiction medicine as part of their training, they are seeing quite a bit of, adolescents and others who are seeing precipitation of acute psychosis and other situations because of the toxicity of the THC content. So this is going to be one of those things. I don't want to get ahead of ourselves, but eventually when this does happen at Schedule 3, looking at the THC concentrations is going to be very important because it does have effect on human body. So it's going to be important to make sure that we're looking at that, what the concentration, because all of that is largely unregulated at this point.
There's no FDA amount of THC that's recommended right now.
Exactly. So there's going to be a lot of research, but the research has been prevented at the same time. It's a catch-22 situation we're in. You can't do research to understand that much, much less have a recommendation that shows this is how much you could use for so-and-so condition. This is how much is not recommended or toxic.
I mentioned all the states where they've legalized it recreationally, medicinally. Federally, though, it's still illegal. Do you think, is there a push? Should Congress be moving ahead with legislation to legalize marijuana?
Well, one of the reasons that President Biden took the action is because he did wait on Congress, and movement did not happen. So, of course, Congress has the ability to move forward in any way it wants to. But at the same time, we just can't stay still because too many lives are at stake, both from the criminal justice system and also from the benefits of it. So it's important that as an administration, we're doing what can be possible from an administration standpoint. It's both evidence guided as well as guided by law that currently exists to take this process on and assure that we're doing everything possible when it comes to, again, this policy that has been in place for decades and decades and has not helped the American people.
So now that it's Schedule 3 and it's alongside Tylenol, what's the message to Americans about using it? And you're a doctor. What would you tell your patients who are like, I'm thinking about, doing marijuana on the weekends?
I think when those products are developed and they're available in the market and FDA approved, it will give providers another option. And oftentimes those options are important because right now we have a few non-pharmaceutical options when it comes to, I'll use the example of chronic pain. We have some non-opioid pharmaceutical options, and then we have opioid options. But oftentimes some of those are not covered by your insurance company, or you're not able to get access to all of these options, and therefore, it's really important to look after people who have chronic pain, who have disability, who have other challenges, and this will, I think, allow the healthcare system to have more options to treat people with compassion. Make sure that when we look at it, we can compare medications, what is available, what is not available, what is the prescription cost, how much copay there is. So there will be systems in the future that will be developed that will probably be less expensive and more legal, you can say, in that sense, because there will be through Schedule 3 regime that will be there.
Where are we when it comes to the opioid epidemic? If we spoke, 6-7 years ago, height of Purdue Pharma, doctors sort of pushing people. Have we resolved that element of it? I mean, is the more concerning part the fentanyl when you look at the big picture of overdoses in this country?
Yeah, so we if you start at the early 2000s, we began with the overprescribing, overwhelming community. There's so much opioid prescriptions out there that there was a lot of misuse and abuse of these medications by common population who was not being prescribed for it. We have since moved to when we started to curtail that turned into more street heroin. And then heroin started to become cut with or mixed with fentanyl. And now it's a lot more fentanyl, even being mixed with a new drug called xylazine or an animal tranquilizer on the street. And in some areas like Kensington in Pennsylvania and Philly outside, 90% or more of the drug supply of fentanyl is mixed with xylazine. We're seeing big challenges, and that's the reason that I declared xylazine as an emerging threat last year early on, to make sure that we have systems and places for addressing that. So now we are addressing fentanyl test strips, xylazine test strips, service programs, naloxone availability. Chronic pain still is a problem, and prescribing, while we are trying to get the pendulum to swing back in the middle, we want to make sure that people have access to the prescriptions, but not over access in a way, if somebody's getting a tooth pulled, it probably doesn't make sense to write a month worth of an opioid. So those type of things is still being monitored and important. At the same time, having the Schedule 3 marijuana and products coming in through FDA approval process will give that extra tool to providers, doctors, and others to be able to prescribe that.
One conversation that's happening out there in some states is about magic mushrooms, psilocybin. I wanted to get your perspective on that. How closely are you monitoring potential medical uses that? Because we've seen some preliminary studies out there, especially when it comes to veterans, about the use of that.
Yeah, so it's important to, again, continue to develop the research and the science behind any of these emerging kind of avenues for it. So we're continuing to monitor the science, the research piece of this, obviously in controlled settings, and see where the future brings us to. And this is the same thing that's going to happen with more research on cannabis because of the Schedule 3 change. So I think there's a spectrum where people may not have had the full benefit of some of these drugs or products that the future may bring us. But again, we got to follow the science. We got to be driven by the science.
So I have a lot of parents who listen to this podcast. And, I mentioned earlier, growing up in the 90s, just say no, right? Which not very effective to teenagers to just say no. But now we live in an era where we have the fear of fentanyl and that sort of thing, which is something we didn't grow up with. What is your message to parents about how to navigate the situation when it comes to fentanyl and drugs right now with their children?
It's a really important, as a parent now I will talk, because it's really important. It comes right home. One of the things I say is that dinner conversation or that single phone call, maybe once a week or twice a week, really important with their children. To ask that question, hey, how are you doing? Here's why. Because some of the times it's the parents or another loved ones who can catch early in terms of the lack of social engagements, the falling grades, maybe something else is going on in their lives, to see what do you need? You need help. We're here to help you. Why that's important? Because oftentimes these children are going to then otherwise, if not, because of stigma also, they're going to think, well, let me order some Xanax for myself online. Or studying for exam, I'll order some Adderall for myself. And what tends to happen now is 7 out of 10 pills that are coming from purchases online have potentially lethal doses of fentanyl in them. So we're telling people that this is something really important to have a conversation with your children and make aware to them that if you need help, please reach out and we'll get you to a provider and you can get the help. There's no harm in that. In fact, we put out a real deal on fentanyl.com messaging, which is young people speaking to young people, talking about 2 things primarily. 1, fentanyl is dangerous. It's in counterfeit pills. You got to avoid it. And 2, carry naloxone or Narcan, because the best thing can happen is you don't have to use it for you, your family, or your friends. And the worst thing could be that there may be a stranger that you don't even know that you'll save their life and be a hero by carrying it. So this is not about stigma. It's actually about having something in your hands, just like you have CPR training and others. So this is the reason why. We've just had a White House challenge to save lives from overdose. We have 150 different public-private sectors like Delta and Southwest and others who have joined. One of those is LA Public Schools. And LA Public Schools have now used naloxone dozens of times since joining. That's saving lives. That's common sense. That makes sense to make sure that we're all part of the solution. We all have the ability to save life because it is so prevalent. But the prevention message still is so important.
So you're talking about every American should have naloxone in their home.
Absolutely. I think it's an important piece, just like we have fire extinguishers, fire alarms. We have defibrillator devices in malls and in planes and airports and public avenues. It's really important to think about that in restaurants and businesses to have that. Look, the prices are coming down as low as I've seen, $24 a kit. It is available now in this administration over the counter even. There's no reason not to have it in your medicine cabinet because, again, hope that day doesn't come, but on your street, next door, somewhere else in the community, there could be someone overdosing that you may not even know about.
Dr. Gupta, thanks for the conversation and look forward to continuing it in the future.
Thank you for having me all. We appreciate it, and thank you for the great work as well.